All right, let's break down cardiovascular pathophysiology in a way that's actually going to stick for your exams. I want you to think of the heart as this incredible high-performance engine. We're going to pop the hood, look at the plumbing, the electrical system, and exactly what happens, step by step, when things start to go wrong.
I mean, just think about it. This amazing machine beats over 100,000 times a day, every single day, without you even thinking about it. But for your exams and for your patients, you need to be that expert mechanic who knows precisely what's happening when that perfect, reliable rhythm suddenly fails.
So to really understand what goes wrong, we first have to completely master what goes right. And the easiest way to do that is to think of the heart as two separate but perfectly coordinated systems. You've got the plumbing and you've got the electrical wiring. First up, the plumbing. It's really just a beautiful, simple four-chamber loop. So picture this. Deoxygenated blood comes back from its trip around the body and dumps into the right side. From there, it gets a quick shot over to the lungs to pick up a fresh tank of oxygen. Then it comes back to the left side, all revved up and ready to be pumped out by that powerful left ventricle to every single cell in your body.
Okay, now for the electrical system. This is the wiring that actually tells the pump when to squeeze. The whole thing starts with a spark from the SA node, which is the heart's own natural pacemaker. That signal travels down and pauses for just a split second at the AV node. Now, this pause is absolutely crucial. It gives the ventricles time to fill up with blood completely. After that little pause, the signal zips down the Purkinje fibers, telling the ventricles to give that big, coordinated squeeze. So, what happens when this perfectly designed machine starts to break down? Well, it sends out warning signals. And for your exams, and more importantly, for your patients, you have to be a detective who can read these clues. We're talking about both the chemical evidence in the blood and the electrical evidence on the screen.
Here is the single most important thing to remember about troponin. It is supposed to be inside the heart muscle cells. That's its home. So if you find it floating around in the bloodstream, it's a direct, undeniable sign that those heart cells have been damaged so badly that they've literally burst open and spilled their contents. That's why it's the absolute gold standard lab test for a heart attack.
Now this is something you are pretty much guaranteed to see on an exam. Potassium is the key player in the heart's electrical stability. If you have too little of it, that's hypokalemia, the ECG gets weird, with flattened T waves and these little U waves, which basically scream instability. On a flip side, if you have too much, hyperkalemia, you get these super tall, pointy T waves because the whole conduction process slows way down. The key takeaway? Both extremes are incredibly dangerous and can be lethal.
All right, so we've seen the chemical clues. Now let's really zoom in on what happens when the wiring itself goes haywire. We're going to look at the pure electrical evidence right on the ECG strip. And to do that, we have to start with our perfect baseline.
And here it is. This is our baseline. This is what perfect looks like. Normal sinus rhythm. The rate is nice and calm between 60 and 100. The rhythm is steady as a drumbeat. And most importantly, you see that for every single P wave, there's a QRS complex right behind it. It's the perfect electrical harmony we're always looking for.
And then you have this. This is the chaos of atrial fibrillation. Look at it. That steady baseline is gone. It's replaced by this shaky, totally irregular mess, and you can't even find a clear P wave. That's because the atria aren't doing their job. They're not contracting, they're just quivering. And here's the biggest danger with that. When the atria just quiver, blood doesn't move properly. It pools, it forms clots, and those clots can get shot straight up to the brain, causing a massive stroke.
Okay, this slide shows a progression that you have to be able to recognize in a split second. On the left, we have ventricular tachycardia. Yeah, it's super fast and very dangerous, but you see how it's still an organized rhythm? The immediate danger is that it can fall apart and degenerate into the rhythm on the right, ventricular fibrillation. And VFib, that's not a rhythm at all. It's pure, deadly electrical anarchy.
Let's be crystal clear about this. VFib means the heart muscle is doing nothing but quivering uselessly. There is zero cardiac output. No pulse, no blood is getting to the brain or anywhere else. This is cardiac arrest. The only, and I mean only, answer is to start CPR immediately and defibrillate them. Every single second matters.
All right, let's switch gears. We've talked a lot about the electrical faults, but now let's go back to the plumbing problems. What happens when the heart's own fuel lines, the coronary arteries, get clogged up with plaque? This is the world of coronary artery disease.
You have to remember, the heart muscle is working so hard, it needs its own dedicated fuel supply. That's the job of the coronary arteries. So when plaque builds up and blocks one of these arteries, the heart muscle downstream is literally being starved of oxygen. If you don't restore that blood flow fast, that tissue begins to die. And that, right there, is the definition of a myocardial infarction, a heart attack.
So how do we fix this clogged pipe? Well, the most direct way is to head to the cath lab. A cardiologist carefully threads a tiny catheter right up to the blockage. Then they inflate a small balloon which squishes the plaque flat against the artery wall. And usually, they'll deploy a tiny metal scaffold, called a stent, to prop that artery open and make sure it stays open. The whole goal is just one thing: get that blood flowing again.
But what if a stent isn't enough? If the blockage is too long or too tough, or there are just too many of them. Well, that's when surgeons need to perform a bypass. They take a healthy blood vessel from somewhere else in the body, like the leg, and they literally build a new highway for the blood to travel on, creating a detour that goes right around the clog.
Okay, let's pull all of this together and make it really practical for your exams and for your future practice. After all these major procedures, what are your absolute non-negotiable priorities? This is where your sharp assessment skills become truly critical.
After a cath procedure, you're on a high alert for a few key things, but your number one top priority is circulation. That means you are constantly checking the pulses below where the catheter went in. A weak pulse, a cool limb, or a pulse that disappears entirely, that is a code red emergency. It could mean a clot has formed. Of course, you're also watching for bleeding at the site and keeping them on the cardiac monitor. But that distal pulse check, that's the one you can never, ever miss.
And for the patient who's going home after major open heart surgery, your teaching is everything. You're the one who's going to teach them to hug a pillow tightly against their chest when they cough to protect that new incision. You're going to drill into them the activity restrictions: no pushing, no pulling, no lifting. And you're going to make sure they know exactly what signs of infection to watch for. This education is what keeps them safe and prevents major complications once they're home.
So, we've mapped it all out: the wiring, the plumbing, the warning signs, the high-tech fixes. But now it really all comes down to you. When you're in that critical moment with everything we've just visualized, what's the one assessment you will prioritize above all else to make the difference? Really thinking that through right now, that's what will truly make you exam ready and ready for anything.